Welcome everyone to our first BJJ podcast of 2026. I'm Andrew Duckworth and a warm welcome back to you all from your team here at the Bone and Joint Journal. As always, we'd like to thank you all for your continued comments and support, as well as a big gratitude to our many authors and colleagues who take part in the series that highlights just some of the great work published by our authors each month. So today for our podcast, I have the pleasure of being joined by an author from not one, but three papers published in the January edition of the BJJ, looking at the 5-year results in terms of clinical and radiological outcomes, as well as the cost effectiveness of the SWIFT trial, which looked at early surgical fixation versus cast immobilization for adults with a scaphoid waist fracture. So today I have the absolute pleasure of being joined by my colleague and friend, Professor Joe Dyers from Leicester. Joe, so pleased to have you with us today. Thanks for joining us.
Thank you, Andrew, for inviting me to discuss the SWIFT 5-year results. It was a great way to start 2026 that on the 1st of January, we had 3 papers. I'm so grateful that they've all come out together.
Absolutely, I think they really do fit well together, don't they? And well, obviously that's what we'll be talking about a bit today. So Joe, to kick off, maybe I thought that for our listeners, I'm just going to take you back, and it'll be probably over a decade now, when this all started, and it will be chewing over in your mind, I'm sure. Before the SWIFT trial, can you give our listeners an idea of what the current state of the literature and practice was prior to the study, and what the landscape was like at that stage before you started SWIFT?
I think it all started 42 years ago. In 1984, Tim Herbert described the headless Herbert screw. It was an excellent innovation. It simplified the method of stabilizing a fracture of the scaphoid, which is a bone that is covered with articular cartilage, which you want to preserve.
Mm-hmm.
Tim went on to recommend its use for all acute scaphoid fractures. And colleagues acutely fixing scaphoid fractures claimed various benefits for this method, including that union was quicker, there was no need for immobilization, earlier return to function, less time off work, and earlier return to sport.
Mm-hmm.
So all these suggested benefits sounded very attractive. The surgical technique itself was quickly well established, and colleagues from around the world, Europe, Australia, Canada, US, started fixing scaphoid fractures acutely as a treatment of choice. This got taken up within the UK, and this led in the 90s and the early part of this century, with several of us starting to investigate in small randomized controlled studies whether there were benefits, whether the benefits that were suggested were actually seen.
Mm.
We ourselves reported a randomized study in a small cohort of 82 patients in 2005 and demonstrated that at 8 weeks, patients who had internal fixation were performing better than those that were put in a cast. But bear in mind that at 8 weeks, you've only just taken patients in a cast out of the cast, so that was not unexpected. After 8 weeks, there was no difference in pain, function, or wrist movement. Between 6 and 12 weeks of the 44 that were treated in a cast, in 10, we were not certain about union, and we investigated it on CTs and also offered surgery, which got taken up by 7. We operated on these, and 4 of these, there was no movement at the fracture site, and all went on to join. We reviewed this particular group 7 years later and established the rate of arthritis after this injury. But there were no other differences that were noted between those that were fixed and those that were not fixed.
Mm-hmm.
But at around that time, there were other studies published which had different conclusions, some showing benefit to having early stabilization. So there was an element of uncertainty. In spite of this uncertainty, there was a rapid adoption of early internal fixation of scaphoid waist fractures. In England, for example, the hospital episode statistics showed that of the expected 4,500 acute scaphoid fractures in England, 1,500 were internally fixed, that is a third, in 2007. And by 2009, 2,500 were internally fixed. So the rate had increased to over 60%. The rate of internal fixation was increasing, even though there was no clear evidence of benefit for early internal fixation.
Mhm.
Both these factors, the uncertainty from previous small studies and the increased rate of internal fixation of acute scaphoid fractures, led us to propose the SWIFT study.
Yeah, Joe, thank you. That's such an amazing overview of, and do I remember then in terms of that huge explosion? I didn't really know those numbers about from the HES data. That is incredible, that increase over that 2, 3 year period to the number of people that were being fixed. And I think you're right. I think what was driving that was the this sort of data from those smaller studies, and particularly that maybe quicker return to function that was perceived was a big driver of that. That's really interesting. I think really sets up nicely why you developed the Swift study. So if we go on to that. Joe, and we move on, before we move on to the 5 year studies, which we're going to discuss, which are in this month's journal. If we then just maybe discuss the Swift trial, how what the design of it was, what the primary aim was, and any sort of key factors in the design or the protocol.
The Scaphoid Waist Internal Fixation for Fractures trial, the SWIFT, was a pragmatic, randomized controlled superiority trial, which aimed to see if surgery for acute scaphoid fractures improved results.
Hmm.
We randomized patients with a clear bicortical fracture of the waist of the scaphoid to either having internal screw fixation within a fortnight or to be initially mobilized in a below elbow cast for around 6 weeks and only to fix those where the fracture was not uniting. At 6 weeks, if on scaphoid x-rays there was any doubt about the state of union of the fracture, this doubt was resolved on a CT scan. The main emphasis was to confirm the state of union using the CT scan. If there was a clear gap across the entire surface of the fracture, then this was defined as a non-union. And if a non-union was confirmed, that patient was offered immediate internal fixation.
Mm-hmm.
The main outcome of the SWIFT study was the patient-rated wrist evaluation, or the PRWE score, which is based on 15 questions, and it allows you to have two domains around pain and around function. The score ranges between 0 and 100, and 0 is a normal wrist without any symptoms. The PRWE, minimum clinically important difference that had been established prior to the study, but only for distal radius fractures, was 11.5 points. We used 6 points, which is almost half the previously established minimum clinically important difference, but we were not certain whether the previously established difference would apply to scaphoid fractures. So we were being quite conservative and knowing that we might over-recruit.
Yeah.
But it also gave us the confidence that we were more likely to be certain of the results that we got.
Hmm.
We did the power calculations, and based upon the smaller difference, we set out to randomize 438 patients with acute scaphoid fractures so that we could retain at least 350 of them at 1 year.
Yeah.
The key secondary outcomes were fracture union, which we assessed on CT scans at 1 year, and complications, establishing the harms of each method of managing the broken scaphoid.
Hmm. That's really interesting, Joe. And I think it's amazing how, like, how from the literature you had, the basis, and then the trial has like very clearly been set up to try and address those concerns and questions, particularly with the size of the trial, like you've done, and also looking at that key outcome, like you say, of non-union. And in terms of that, Joe, for people who obviously the main results for the 1 year results were published in the Lancet. I think it was in 2020. It was. What were the key findings from that? And anything in particular in terms of the secondary outcomes you'd wanted to highlight as well?
The key findings that we reported at 1 year for the SWIFT study were that there was no difference in pain and function between the scaphoid fractures that were fixed and those that were initially treated in a cast.
Yeah.
The scores were around 11 for those treated um, uh, with fixation and 14 for those treated in a cast.
Hmm.
There was also no difference in non-union rates, which was surprisingly very high.
Hmm.
But moderate or severe complications, things like infection, screw penetration, and CRPS1, were more common in those that had surgery, as one would anticipate. It was 12% with those fixed initially and 2% in those that were initially treated in a cast.
Yeah.
There was quite a big difference in the harms.
Yeah.
What surprised us was the very few days difference in the time to return to work,
Yeah.
which was given as one of the benefits of early internal fixation. The time off work was 16 days after fixing the fracture and 18 days when treated in a cast.
Hmm. Hmm.
Mean times. The median time of work was 9 days after screw fixation and 5 days after cast immobilization. So our patients went back to work even when they were still in a cast, and a third of them took no time off work.
Yeah.
This
Yeah.
is an amazing population.
Yeah, absolutely. I have to say, though, that was the biggest surprise to me from the results because it really was contrasting to some of the previous trials that had really advocated that this was the big thing about early fixation, wasn't it? Was there any hypothesis about why you think that was at all that you felt, or just the findings as they were?
No, I think it was how we practice medicine. And um, in our previous study in 2005, the mean time off work was 5 weeks and 6 weeks.
Mm. Yeah.
So the difference, the thing that changed between then and now was how we advised patients.
Yeah. Yeah.
So we advised, gave them confidence, telling them, yep, get back to work, do as much as you can manage. The bone will take 6, 8, 12 weeks to
Mm. Mm.
unite, but you can still get on and work.
Yeah.
And
Yeah.
those in the cast, what we'd be saying to them is, look, the important thing is to avoid movement. So if the cast broke and it was allowing wrist movement to come back early so they
Yeah.
could cast reinforced.
Yeah.
Um, I, I think it was how we advise patients that changed in between the two studies.
That's very interesting, yeah, and actually totally makes sense. And I think just to highlight for our listeners, Joe, is that key point you said about the design is that early assessment and potential intervention if it's going on to non-union. That's a really key part of it, isn't it?
That is a key part, not comparing cast only
Yeah,
versus fix only.
yeah, absolutely.
Comparing cast plus treat any failures early
Yeah, absolutely.
to early fixation of all.
Yeah, no, absolutely. I think that's a really key point that you highlight really well. And I mean, you mentioned about the non-union, but I think we maybe come back to that when we look at the 5 year outcomes because that's quite interesting how that has progressed. So if we do move on to the three publications in this month's journal, and these were looking at the clinical outcomes, the radiological outcomes, and the cost effectiveness at 5 years, which for our listeners, I'm sure everybody's aware, but to get data at 5 years in a trial like this and the quality of the data, as we'll come on to, is actually incredible, I think. And it's a real testament to Joe and the team to have been able to achieve this, particularly in what is more of a predominantly young and quite mobile population. It's not generally as easy. So, Joe, just for our listeners, what were the key findings and sort of the follow-up that you attained? Really, mainly, firstly, with regards to the clinical effectiveness.
At 5 years, we reviewed all the patients and repeated exactly the same analysis as we had done after 1 year.
Mm,
So at 5 years, the pain and function assessed using the PRWE score was 9.6 after early fixation, and it was slightly better,
mm,
9.1 after initial cast mobilization. This was not statistically different. The union rate was 1% different between the two groups. It was 98% in those treated with fixation versus 97% in those treated initially in a cast. And this difference too was not significant.
mm.
We were really surprised at the rate of union that we saw, particularly as this was a pragmatic study
Yeah,
and did not meddle with the thresholds for decisions in the different units that were recruiting into the study.
yeah,
So that was in how you would expect these decisions to behave in real life.
yeah. No, absolutely.
What we were surprised about initially, just as you mentioned, we were looking after predominantly young working men.
Mm,
And given that population, we had planned when we were planning the study to have to have a 20% attrition at 1 year
mhm,
and further 20% between 1 year and 5 years
mhm,
of the ones that were left. So overall, we were anticipating that we would hopefully retain at least 66%
mhm. Yeah.
at 1 year. What we were amazed about was that at 5 years, 345 of 423, that's 82%, responded. Patients
Mm,
responded. That was amazing.
yeah,
Of course, from the hospitals, we had 412 out of 419. So that is 98% response rate.
that's amazing.
And this has provided us with great confidence in the results.
Yeah, absolutely. I think having 5 year follow-up data at that level, Joey, I think it's just absolutely incredible. And like I say, it's such a testament to the team. And in terms of maybe we'll come to the Radiological Union paper last, actually. In terms of the cost effectiveness, what did it show?
The, the patients randomized to early surgical fixation had higher costs to the NHS of
Mm,
£1,295 more than those treated in a cast early.
mm,
They also had marginally better quality of life
mm,
over the 1 year period of 1% better qualities. Uh, and this difference was not significant.
mm,
But that led to a cost per quality of 82,000
mm,
if you fixed all fractures acutely. This
mhm,
is well above the accepted threshold for cost effectiveness used in the UK, for example, and most other countries as well, of between 20 and 30,000
mhm.
per quality
Yeah.
uh, to commission treatments. The probability of early surgery being cost effective was very tiny in
Mm,
this model of about 5%.
mhm,
At 1 year, our Markov model, which simulates the lifetime impact of the injury on the patient, was based on many assumptions because there was no data on the impact of arthritis, the impact of non-union, etc. 5 years after randomization, most patients in both groups returned to the quality of life level which was consistent with their age-adjusted norms
Yeah.
and did not require any further healthcare.
Yeah.
It also confirmed in the Markov model that was now updated on actual data rather than assumptions that the initial cast immobilization was the most cost-effective strategy, with a cost to our system of 1,066 pounds less per patient compared to those who initially had surgery.
Yeah.
An annual saving, even now, of between 7 and 9 million pounds a year.
Yeah. Absolutely.
These findings confirmed clearly that initial mobilization in the cast with fixation only for non-union that is seen in the tiny number of patients is the optimal cost-effective treatment for these patients.
Yeah, no, absolutely. And I think, like you say, you do a lovely overview of that cost effectiveness, and it's so clear on every marker that you've looked at in terms of whether it be the cost per quality and the overall cost savings as well. And Joe, just finally, before we sort of wrap up, the final thing was the radiologic outcomes, and I think there's some really interesting data you've gathered here at the 5 years regarding that progression to union and looking at arthritis as well.
We were surprised about this as well, which is the partial unions. What we had done was we looked at the proportion of the area of the surface of the fracture that was bridged with bone.
Mm-hmm.
So
Mm-hmm.
100%, above 95%, if it was bridged, it was full
Full
union.
union. Yeah.
And if it was 0%, it was a non-union.
Yeah.
And partial union was between 20% and 70%
Mm-hmm.
bridging. And what we found that partial union, all the patients progressed if there was greater than 20% bridging.
Yeah. Yeah.
And this occurred without any intervention and any modification or protection. And this is consistent with the finite element analysis work both from Switzerland and from the UK.
Mm-hmm.
So from a union point of view, we found that partial unions progressed. The other surprising thing that we found was the ones that were fixed, they still had a screw or an implant inside.
Mm-hmm.
And therefore, of that group, the ones that were fully joined at 1 year, which is greater than 95%, more of them were less than 95%.
Mm-hmm.
And what was happening was stress shielding.
Yeah, yeah,
And,
yeah,
and how so, and more of them, but of course, it was a functional scaphoid
yeah, yeah,
and had no impact. But it was interesting to see that even the act of putting in a screw
yeah,
changes how the physiology works and how the bone remodels
yeah,
over 5 years.
yeah,
So that was union, and
yeah.
both those were interesting observations. One of which is so reassuring for patients.
Mm,
The second thing that we found that was quite surprising was at baseline, that is, at the time they came into the study, 10% had arthritis. It was
yeah,
9.8%, around 10%. So 1 in 10 had pre-existing arthritis in one of the joints of the wrist. At 1 year, this increased to 27%,
mm,
and at 5 years, it was 52%. So
yeah,
that is half of them were showing changes of arthritis, mostly mild,
yeah,
and mostly around the scaphoid, and particularly around the scaphotrapezium trapezoid joint,
mm.
which was seen more frequently in the ones that were fixed. And I think it is to do with the approach and possibly leaving a thread or two
In that
of
joint,
the
yeah,
screw.
yeah,
So there was an impact. Mostly, although the rate of arthritis was higher, and we think this probably reflects the injury to the cartilage because the rate is the same in both groups.
hmm, yeah,
It tends to be mild at 5 years,
hmm,
but it did have an impact on the PRWE,
The prom,
although
yeah. Yeah.
very tiny impact.
Yeah, no, absolutely, Joe. I think that, like I said, Joe, that to me, what the fascinating, I mean, all amazing radiological data that, but that line of fractures with a minimum of 20% union at 1 year consolidated with the passage of time without intervention is really interesting data, isn't it? And actually, I think, in my clinical experience, anecdotal, that does occur. You do get people who just are very slow to heal, but they do heal. And I think that gives great reassurance. And going back to the original protocol in terms of intervening at 6 weeks if you're concerned. These are really for ones where there is nothing at all there, isn't it? It's for that there is a non-union. But if there is some consolidation there, and certainly 20%, you're probably okay to run with it. Is that your sort of take with it as well, Joe?
Pretty much. And we
Yeah.
know that the amount of bridging that you need to do
Yeah.
activities of daily living
Yeah.
is between 20 and 30%.
Percent. Yeah. Yeah.
Uh, so you don't need to protect.
No, absolutely, absolutely. Well, Joe, and that's a great overview of those studies. And I suppose just to wrap up, just a few final quick questions. So, do you feel, this has been like sort of your baby for 5, 10 years now. Are there any limitations or caveats to the key take-home messages? I mean, I think we've covered most of them, but anything you want to highlight in particular?
I think the important thing with all these studies are the exclusions
Yeah, yeah,
in the study. So the results, to be absolutely pure about this, the results do not apply to the ones that were excluded. So
mm,
that those were the ones that were displaced more than 2 millimeters
yeah,
or to proximal pole fractures. But
yeah,
both these are uncommon and account for less than 1 in 20
yeah,
of
yeah.
acute scaphoid fractures. So the results are relevant to the vast majority of scaphoid fractures we see.
hmm Yeah, absolutely. And looking back now, is there anything about the studies that I always ask this of a lot of our authors, anything you would change now, knowing what you know in terms of the design or anything?
From the study itself, not much.
Yeah, yeah,
And I think the team has been fantastic
yeah.
from all the elements of the team. And also the colleagues, the clinicians that contributed to this have been amazing.
Hmm hmm
Because we have discussed all our uncertainties as we went along with the whole team
Yeah,
and resolved them as we went along. And I think, and that was not just the clinicians, but also patient
yeah,
advisors. And that was really useful. How we practice is different. We
yeah,
spend more time explaining to the patients why their scaphoid fracture, an injury that looks so trivial when you look at it, has the potential to affect this young man's future wrist and hand function. And we explain to them that they are part of our team to
yeah,
achieve union,
yeah,
and that by achieving union, we protect the function of the wrist.
yeah, absolutely.
Is
Yeah.
the first thing. The second thing that is clear to us is that we should be advising all our patients about activity,
hmm
even when they're recovering
Yeah,
fully. And this is what I mentioned earlier, that we need to explain to them that there is no harm, and we now have the proof there is no harm
yeah,
with them returning to work. So we are very much more confident about saying, get on with life, use your hand for day-to-day stuff. If the cast is soft, then come back and get it reinforced.
yeah,
We reassure them that partial union, the thing that looks not quite right, even at 1 year, goes on and consolidates. And
yeah,
we are not worried about it. And actually, it just proves that nature is an absolutely beautiful thing.
totally.
And although there is the consequence of the injury with arthritis rates going up to 1 in 2 by 5 years, the severity of arthritis is very, very mild. So
Mm.
we're not overly concerned about
No,
that.
yeah, absolutely. I mean, Joe, I think that's a lovely way to actually finish off in terms of that. I think those are all those lovely key take-home messages from Swift, and actually just an example of how, really well designed, big, generalizable, pragmatic trial has really, changed the landscape of what was normal practice, or was becoming normal practice back then, and is now we have a practice based on real robust data. And I've really enjoyed talking to you today, Jonah. I think our listeners have learned so much from not only from the work, but hopefully from what we've chatted here today. And just a massive congratulations to you and all the team on such an incredible body of work, which has added so much high quality literature in this area, not just in terms of the clinical outcomes, but the radiological outcomes as well and the cost effectiveness. And it's been amazing to have you with us.
Thank you, and thanks a lot.
And to our listeners, we do hope you've enjoyed us joining us, and we encourage you to share your thoughts and comments through our social media platforms and alike. Feel free to post about anything we've discussed here today. And thanks again for joining us, everyone. Take care.